Scott Brown's Rhinology, Chapter 87, Anatomy of the Nose and Paranasal Sinuses. Today we are going to learn about paranasal sinuses. Paranasal sinuses. Anatomy of the paranasal sinuses can be divided into anatomy that has surgical relevance and descriptions that are academic in nature. Surgical anatomy of the paranasal sinuses. Traditional descriptions of paranasal sinus anatomy focus on pneumatization patterns of air cells with corresponding clefts and spaces. Such descriptions are academic and have little clinical relevance to modern endoscopic sinus surgery. Although an understanding of the sinonasal anatomy is critical to ensure safe and complete endoscopic sinus surgery, the concept of pneumatization pathways and development is highly variable and often distorted by disease or prior surgery. Endoscopic sinus surgery is an exercise of anatomical dissection around fixed anatomical landmarks. Akin to traditional mastoid surgery, the sinus surgeon must identify certain key anatomical landmarks in order to delineate the limits of dissection. These landmarks must be based on fixed anatomical structures rather than variable anatomy that can be distorted or absent from disease processes or prior surgery. The goal of the surgery is to identify these landmarks early during the procedure in order to provide orientation for the remainder of the operation. These consistent landmarks include 1. Maxillary sinus, 2. Orbit from the maxillary roof or orbital floor, and medial orbital wall lamina pepracia, and 3. Skull base identified posteriorly by the sphenoid sinus. These defined anatomical limits establish the boundaries of the paranasal sinus box, including the horizontal and vertical components of this box. The concept of the paranasal surgical box forms the basic framework of endoscopic sinus surgery. The boundaries of the horizontal portion of the paranasal surgical box include middle turbinate medially, medial orbital wall lamina pepracia laterally, floor of nose inferiorly, and skull base superiorly. The boundaries of the vertical portion of the paranasal sinus surgical box include middle turbinate and intersinus septum medially, lamina pepracia laterally, nasofrontal beak anteriorly, and skull base posteriorly. Figure 87.14 schematic diagram of the right paranasal sinus surgical box. A horizontal component of right surgical box with limits of dissection including medial orbital wall in blue, middle turbinate in gray, skull base green, sinus sphenoid sinus yellow. B is a vertical component of the right surgical box with limits of dissection including medial orbital wall blue, middle turbinate gray, skull base green, anterior nasal beak red. C is a combined schematic diagram of the horizontal and vertical components of the paranasal surgical box. Figure 87.15. A is the endoscopic view of right horizontal component of the paranasal surgical sinus surgical box with the medial, lateral, superior and inferior limits of dissection visible with a single portion of the endoscope. The lateral, medial, and superior boundaries of the horizontal surgical box are indicated as B. Medial orbital wall in blue, C. Middle turbinate gray, D. Skull base in green, respectively. E is a sphenoid sinus yellow, serves as an important landmark to identify the skull base at its most posterior position. Upon completion of maxillary and antrostomy or any maxillary sinus opening, identification of the maxillary sinus roof or orbital floor exhibits the first key anatomical landmark. This landmark first provides the location of the orbit and then provides a safe working distance from the skull base during identification of the sphenoid sinus, whether via the natural ostium or not. Although conceptually the floor of orbit should be below the skull base, anatomical studies have demonstrated that the maxillary sinus roof or orbital floor was below the level of the skull base, lowest point of the cribriform plate, in 100% of cases with a mean distance of 10.1 plus or minus 2.7 millimeter. This landmark was also found to be below the level of the sphenoid planum in 100% of cases with a mean distance of 11.0 plus or minus 3.7 millimeter and located at approximately 50% the height of the sphenoid. As a surgical rule, staying below or at the level of the maxillary sinus roof or orbital floor as dissection proceeds posterior will avoid the skull base. Although a well pneumatized maxillary sinus reduces the height of the posterior ethmoid cavity and may lead to poor surgical trajectory and skull base injury, this surgical rule still applies. The ethmoid bulla is attached to the medial orbital wall lamina pepracia laterally. With the orbital flow on view, removal of ethmoid bulla enables identification of a second key anatomical landmark. Identification of whether the floor turns vertically or to become the medial orbital wall enables safe exposure of the entire orbital axis and delineation of the lateral boundary of the paranasal surgical box. The third key landmark of the sphenoid sinus or posterior skull base. The maxillary sinus roof or orbital floor landmark is used as a reference to mark the level of sphenoid ostium. Any dissection medial to the orbital axis and or below or at the level of the orbital floor will allow safe entry into the sphenoid. While structures such as the superior turbinate are incredibly useful in defining the medial boundary of dissection for the ethmoid cavity. This structure cannot be relied upon as it is often removed by pathology or previous surgery. Opening of the sphenoid ostium and removal of the anterior sphenoid wall enables clear visualization of the posterior skull base. The skull base slopes downwards from anterior to posterior, thus, the posterior skull base is at its lowest height within the horizontal portion of the paranasal surgical box at the level of the sphenoid sinus. The sphenoid can be widely opened laterally as the orbital axis, and thus the lateral limit is previously identified. Once the posterior skull base is identified, all four limits of dissection, the horizontal portion of the paranasal surgical box, are defined, and all cells within the confines of these boundaries must be removed. Performing a complete dissection of the horizontal portion of the paranasal surgical box serves to define the limits of dissection for the vertical portion of the box. The limits of the dissection that are defined during complete sphenoethmoidectomy include the medial orbital wall laterally, middle turbinate medially, and skull base posteriorly. These limits are extended superiorly to define the boundaries of the vertical portion of the surgical box, and all cells within the confines of these boundaries are removed. Figure 87.16 A. Endoscopic view of the left vertical component of the paranasal surgical box with anterior, posterior, medial, and lateral views of dissection visible with a single portion of the endoscope. The anterior, posterior, medial, and lateral boundaries of the vertical surgical box are indicated as B. Nasal beak in blue, C. Skull base blue, and Posterior table of frontal sinus in green. D is the middle turbinate in blue and frontal intersinus septum green. E is a medial orbital wall blue and supraorbital floor roof green respectively. Figure 87.17 maxillary sinus roof or orbital floor landmark. Endoscopic view of right maxillary sinus anastrostomy. Asterisk indicates the position of the right maxillary sinus roof and or orbital floor, which serves as the first surgical landmark during endoscopic sinus surgery. Figure 87.18 endoscopic view of right maxillary sinus antrostomy after removal of anterior ethmoid cells and basal lamella. Line indicates the horizontal relationship between the maxillary sinus roof or orbital flow landmark and position of the sphenoid ostium. White oval indicates the relative position of the sphenoid ostium. Application of this landmark will ensure safe and easy identification of the sphenoid sinus and avoids mistaking a posterior ethmoid cell or onode cell asterisk for the true sphenoid sinus. Note that within the onode cell is the presence of an exposed optic nerve. Arrowheads. Figure 87.19 endoscopic view of right anterior ethmoid sinus cavity. The position of the right medial orbital wall asterisk is identified after removal of the ethmoid bulla. The transition from the orbital floor to the medial orbital wall is clearly delineated by the arrow. Figure 87.20 endoscopic view of right sphenoid sinus cavity. The position of the posterior skull base arrow is identified after removal of the anterior wall of the sphenoid sinus. The positions of the orbital wall asterisk and medial orbital wall arrowheads landmarks are visible with a single position of the endoscope. Box 87.12 endoscopic sinus surgery is based on the identification of key fixed anatomical landmarks, including orbital flow, medial orbital wall, sphenoid sinus, and posterior skull base. These landmarks help to define the anatomical limits of dissection during surgery and establish boundaries of the paranasal surgical box, including the horizontal and vertical components of this box. The horizontal components of the paranasal surgical box includes the medial orbital wall laterally, middle turbinate medially, and skull base posteriorly. These limits are extended superiorly to define the boundaries of the vertical component of the paranasal surgical box, which includes the middle turbinate and intersinus septum medially, lamina papyracea laterally, and nasofrontal beak anteriorly, and skull base posteriorly. Thank you.